Good morning. Good morning and welcome to the U.S. launch of Our Future, a Lancet Commission on Adolescent Health and Wellbeing. And this is a discussion, which we expect to be great, among commissioners, funders, and you on the findings and how we will incorporate those findings in our policies and programs which each of us influence or engage in. My name is Cassandra Jesse. I am the Director of YouthPower Learning. It's a USAID-funded project. I am representing Making Sense International and the International Center for Research on Women. I could not be more thrilled to be among so many esteemed hosts for this event. This is co-hosted by the U.S. Agency for International Development, the President's Emergency Plan for HIV/AIDS Relief, YouthPower Learning, the World Bank Group, Bill and Melinda Gates Foundation, and the Lancet. I want to thank my team and the co-hosts for helping to make this event happen today. We express our gratitude to the Kaiser Family Foundation for this beautiful space and to Spark Street Digital for their support on the web streaming. And we thank each of you for your role as champion for youth development and for joining us here today. We hope this will be a fruitful exchange and have a long-reaching influence on the work that we do in supporting youth around the world. I trust everyone found breakfast this morning and have seen the reports on your chair. Yes, the internet is down. It should be coming up. They are working on it. When it does come up, it is KFF, and there is no password. So for those of you online, hopefully everything is coming through just fine. If anybody needs anything, those of us with red name tags are here to assist, and we'll be glad to help. Bathrooms are around the corner and those kinds of things, so happy to help. Without further ado, I would like to introduce Dr. Soji Ade. He is the Director of Health, Nutrition, and Population Global Practice at the World Bank. So please join me to welcome him.
Good morning. It's a great pleasure to be here on behalf of our team and our leadership at the World Bank. Thank you very much. And I also want to express sincere thanks to our colleagues from partner agencies in pulling this off, and great gratitude to the Lancet for the wisdom in making this happen. So to USAID and PEPFAR and YouthPower, and of course, the Bill and Melinda Gates Foundation. It's great to be here. I also want to thank our hosts for, among other things, not only this very pleasant room, but as you might have noticed when you came in this morning, they actually arranged for very nice weather. So it's great to have friends who have connections. Yeah, my name is Soji Ade, and I serve as Director of Health, Nutrition, and Population at the World Bank Group. Well, why are we here? We are talking here today about adolescent health and well-being, and we will do a deep dive. We're going to learn a lot. But the headline really is the following. This is a topic that is at the convergence of health, of the development of human capital, of the deployment of that human capital, of social justice and fairness, and yes, hard-nosed pragmatism when it comes to economic development. That is what we're talking about today, and I hope that each and every one of us, whatever frame we've brought to this, we can find in it something from which we can learn, we can find in it something that we can celebrate, and we can find in it something that can re-energize us as we go back to our duty stations with a commitment to doing better and doing more, both individually and perhaps more importantly, collectively. I happen to be the father of two adolescents, so I have a personal take on this as well. But I will not get heavily into that, otherwise I might be guilty of what my kids often say, which is, "Dad, you're so embarrassing." Now, almost 1 in 4 of the population of the world is a young person between the ages of 10 and 24 years. and most of those live in developing countries. And they grow up in a fast-changing and challenging social context. It's full of opportunities. It's also full of perils. We have unparalleled access, or the potential of access to technology, educational opportunities, and all that comes with globalization and the potential benefits of health systems. Yet, in order for whole societies to take advantage of these opportunities that they present, or shall I say potential opportunities, it is important to put in place and execute the right policies. Let me draw attention to a topic that is often in the news these days, and that is the demographic dividend, which, as many or most of you will know, is at the interplay of changes in the structure of populations due to fertility declines on the one hand, and economic development on the other hand. But the demographic dividend is not automatic. You can also have a demographic disaster if there is a youth bulge and that youth cohort is poorly educated or does not have the proper skills or does not have access to the workforce, does not have access to financial markets, and all the social opportunities and empowerment that are necessary for a society to channel that potential into huge social and economic gains. And it could also be, unwittingly, a foundation for social instability, because everybody now has access to the web and they know what they're missing. So I hope this begins to concentrate or reconcentrate our minds collectively on why it is so important to take seriously the topic of adolescent health and well-being. Now, in addition to the well-known and more talked about challenges of infectious diseases that are linked to the social context, risky behaviors, say like infection with HIV, for example, we're also talking about the risks and challenges that come with lifestyle choices. And sometimes the choices people make are heavily influenced by the social constraints to which they are exposed. They are not separable in most cases. So what is the role of public policy in this? What are the duties of the state or the duties of the government? And what are the functions in a collaborative way of international agencies, be they research institutions or financing institutions, think tanks, foundations, civil society organizations? What are their roles? How can they collectively be more useful to those societies? These are some of the things we are going to talk about today. We also need to keep in mind that, in fact, while we're here talking about the health of adolescents, some of the most important things to adolescent health cannot be achieved through classic health sector interventions as we know them. So if we are talking about a well-educated cohort of the youth, then we need to do business very extensively with our colleagues in the education sector. And it's not just a matter of schooling, it's a matter of learning. If we're very interested in ensuring that this educated cohort of adolescents, when they become adults, in fact, can be gainfully employed, then it's very important that we talk with our folks who are working in the areas of employment, labor productivity, and also our folks who are working on social protection. If we, for example, are looking at instruments such as conditional cash transfers, for example, that is very important. It's very hard to achieve universal coverage for any cohort if you don't know they exist, if they're not identified. You remember the line from The Invisible Man. He says, "I'm invisible because you refuse to see me." So we need to work with our folks who are working on identification for development so that people actually do count. They can be counted, they can be identified, they can count, and they have access to things that are taken for granted in some other societies, and so on and so forth. If you're worried, for example, about youth at that delicate experimental stage of life, becoming smokers, then you probably want to hike taxes on tobacco. And if you want to increase taxes on tobacco, which I think we should do, I don't think they're high enough. I think taxes for tobacco should be even higher than they are, and I hope the word goes forth from here. Then we need to do business with our macroeconomists who can have highly informed and appropriate conversations with the ministries of finance and trade and commerce, for example. And if we're interested in curbing road traffic accidents, then we need to work with our colleagues who work in that sector as well, road and transport. So this is just the beginning of an illustration of how engagement across multiple sectors come together and how we all can make ourselves useful in this realm. Now, we have a lot of discussions coming ahead of us today. The final point I want to make is for a measure of collective humility as we approach this topic. There is a lot that we don't know. There are some things we know, and in some cases we know the what. We're beginning to understand the how, and we still struggle with the why. And one of the benefits of being in a setting like this is that we can have an informed conversation and appreciate the things that we still need to learn. I would like to challenge us to reflect on how we collectively can support countries when they want to make the transition from small-scale experimentation to large-scale implementation. It's relatively easy to have a successful intervention on adolescents and youth if you're working in just one little district or one small local government. But when you want to work across the whole country, it brings to fore the questions of how societies make choices. And if we're going to be successful there, we need to understand their narrative and be able to positively influence the discourse and the policy choices there. So, again, I want to thank you very much for the opportunity to have this conversation. Looking forward to a lot of learning. And now it is my privilege to introduce my colleague, Dr. Sabina Kleinert, who is the Senior Executive Editor of The Lancet. Sabina.
Thank you very much, and good morning. Welcome also on behalf of the Lancet here to this very exciting second launch of the Adolescent Health Commission. But it's really great that we are already talking about what to do next, because this is what this is all about. So before I start, I want to thank all the organizations and the people involved who've made this possible here in Washington. This is fantastic. Let me talk a little bit about what is a Lancet Commission. Some might say, oh, yes, there's another publication out there, there's another report, you know, that we should read, but this isn't what we are aiming for here with a commission. So this commission took 3 years in the making. I think 3 years, yes, I get nodding from my chairs and other commissioners in the audience. It felt shorter to me, which is a good sign, I think. So what is a commission? To us, it's a scientific review, it's an inquiry, and it's a response, and that's really, really important, to an understudied and an important health predicament that we need to grapple with. So I want to, again, emphasize this scientific basis to a commission, because there are many advocacy reports out there. This is different. This is science-based advocacy. It's also multidisciplinary. It's intersectoral. And we've heard about this already, that we are needing this intersectoral dialogue in difficult areas such as adolescent health and well-being. It is also very much oriented to transformational change. And this is where we talk about policy, about real policy change. So again, this is different. So I always say to commissioners, and they get very nervous when I do that, you know, this is only a beginning. A commission is only a beginning. This is a baseline. And we're talking about a standing commission, which means it continues. We don't want to just put this out and walk away. Definitely not. That's not how we work at the Lancet. We want to continue for 5 years, 10 years, however long it takes to make this transformational change. Why adolescent health, you might ask? And we started very much earlier than this commission at the Lancet to work on adolescent health with 2 previous series. One in 2007, so we've been at this for over 10 years already. But in this very first series, we started very small. We started by just saying, there's such a thing out there as adolescent health. There's such a specialty. Because it sort of sat awkwardly between pediatrics, adolescent medicine, adult medicine, and there was a small group of adolescent health specialists who were talking about adolescent health, but they didn't really move outside their specialty very much. So the second series was necessary, in my view, because we wanted to make them step out into the wider world and engage with the global health community and say adolescent health is really important for global health. And that was the focus of the second series. So why adolescent health? Why now? I think now we have an enormously opportune moment to talk about adolescence. And last year, in September 2015, we've adopted the Sustainable Development Goals. If you look at all the 17 goals, almost all of them, and you might even argue all of them, have something to do with adolescent health and well-being. And adolescents not only as beneficiaries and recipients of action, but also as those who will shape these actions, who will be actually the people who will make this work. So Ban Ki-moon, the UN Secretary General, in his comment, very much spoke about the sustainable development generation, which I think is great, and you should all remember that and have that in your head when we're talking about the how and what to do next. The other reason is we started at the Lancet very much with child survival, children under 5, as our global health series in 2003. And there have been great successes there. There's much more to do, of course, but there have been great successes. But think about it for a moment. Those children who we talked about in 2003, they are now adolescents. So it doesn't make any sense to stop and say, tick, job well done, you know, now we don't think about what's happening next. I think we need to continue this generation and make the best for their future. And third, I think at the Lancet we very much like to think about a better future for society, a better future for people worldwide, and we even say a better future for our whole planet. Adolescents not only deserve our attention now, but adolescents also are this future. They will shape this future. So I would like to invite you all today to think about how we can make all this work together and what we need to do to continue to this topic and achieve this transformational change that I've been talking about. So this is a beginning, remember that. Thank you very much. Now I would like to invite George Patton, who will tell you about what we've all been waiting for, the essence of the Commission. George has been the chair of this Commission, an unwavering chair who has been a pleasure to work with. George is also the Professor of Adolescent Health Research at the University of Melbourne. Thank you, George.
Thank you very much, Sabina. I'm not sure if I should thank you for signing away yet another 5 years of our lives. 10, 15, there you go. Watch it with the Lancet, you never get out. Thank you, Sergi, for your comments, which really resonate with much of what I'm going to be saying this morning. Susan Sawyer and I were last at an event like this 4 years ago in Washington, D.C., where we were launching at that time the second Lancet series on adolescent health. And at that meeting, we had a comment from somebody who I think many of you will know, Margaret Green, who's a prominent figure here, sort of working in international development in Washington, D.C. And Margaret said at that time, the case for adolescent health is overdetermined. What we now need to be doing is deciding what the next steps are and what we should be investing in. So this commission, 4 years on, is really an attempt to say what we should be doing in the adolescent health space. Now, our hosts 4 years ago were independently USAID and the Health, Nutrition and Population team at the World Bank. I'm just so delighted today that you've actually come together with the Bill and Melinda Gates Foundation to sort of be the three hosts of this meeting today. This is an area where we need sort of our major agencies and funders and donors to be coming together, so it's great to have you hosting us. So I'm going to be talking today about the findings of a 25,000-word report. I've got 40 minutes. It's still going to be a bit of a race, so there's a lot to cover. I'm going to be talking about potential and growth. I'm also going to be talking about the opportunities we currently have, together with the challenges, and what we should be doing about those challenges. So let's start with potential and growth. I figure that a few of you have actually had a child go through puberty, and you'll have some memories of what that was like. You will remember the tremendous physical growth that happened at that time. I should move my slides on just a little bit. You'll remember the tremendous physical growth. And you might have been like me, sort of had a son who was one day a little boy, and the next day he was 6 inches taller than I. Humbling experience. What we've failed to realize, though, is that this is a time not just of physical growth, but it's a growth in all bodily systems. It's a time of huge neurodevelopment, a process that really continues through to the mid-20s. And yet, for a long time, we had thought that brain development stopped at the age of 7 years. That was because brains reach their maximal size at 7, but the process only is really beginning at the age of 7. What happens at about the age of 7 is you have the first hormonal changes of puberty, which triggers a whole new phase of growth and development. That's when kids are in mid-primary school. That cascade of hormonal changes, as I said, begins, girls at this time will talk about the boys beginning to smell in class. A cascade of hormonal changes continues all the way through the adolescent years and is accompanied by a cascade of changes in brains, neurodevelopment. It begins with maturation of some of those centers involved in emotional processing. It's one of the reasons why girls in particular, as they go through the pubertal years, they'll often talk about a rise and recognition of new and sometimes difficult emotions. That process of brain development continues all the way through to the mid-20s, ending with the development of maturation of the prefrontal cortex and the acquisition of higher executive functioning. It's a phase of life which is one of incredible sort of exploration, creativity. It's a time of sensitivity to the environment and sensitivity to one's place in one's world. It's a time perhaps of vulnerability also to problems related to emotion and emotional control. It's no surprise that most mental disorders begin during these years. What's not in doubt is that it brings a very different engagement of the individual with his or her social world. It's a time of looking beyond one's family of origin to the wider world. And how that engagement with the wider world, the cultural environment, the social environment, the economic and physical environment shapes, in turn, the very capacities that an individual develops during these years. It shapes identity, it shapes gender norms, values, beliefs, shapes health profoundly, and shapes, as I said, the very capabilities an adolescent takes into adulthood. So it is a time where biologically kids are primed to engage in a very different way with their social worlds. So you might be asking, what do the social worlds of adolescents look like? Well, the first thing to say, it's a time where It's not only great heightened sensitivity, but it's a time of great diversity in the social environment. It's a time where, as Soji suggested, the cultural, economic and social environment sets the agenda in many ways for everything that's happening in the lives of an adolescent. Those shape the legislative frameworks and the policy frameworks, which in turn shape the resources available to young people. It's a time where families remain the most important immediate context for development. But this is a time of change in families. It's a time where an individual moves from a family in which you grew up to a family of your own. And that's a transition which in many parts of the globe has actually become a lot more difficult. And yet it's a transition which is critically important for health and well-being. It's also a time of transition from education to employment. Again, this is a critical transition for health and well-being, as well as everything else in a young person's life. It's a transition where, if we get it right in terms of extending secondary education, as I'll come to talk about, the opportunities are enormous. But it is a transition which is becoming difficult in many places. In North Africa, many parts of the Middle East, the expression of waithood refers to the difficulties that a whole generation is having of making this transition to a family of your own and into independent employment. Now, if it's an age of anything, it's an age of the peer group. And I want you to think about, so this is a time of life where an individual spends more time with peers, and where peers' attitudes and values and behaviours are more significant than any other point in the life course. So think for a moment about how that has changed through human evolutionary history. Think about the village, because it was the village, maybe the neighbouring village, and the cohort of adolescents in that setting, which was the traditional peer group. Think about the modern context. As Soji hinted, the peer group today is potentially the whole world. And why? Because of media. And I want you to sort of think about how media has changed in the blink of an eye. Mass media, and in little more than a decade, the growth of social and digital media, which dominates all our lives. And I like Cassandra's comment about the internet is down. Major trauma. But it particularly dominates the lives of this generation. So this is a time of broadening of horizons. And in that, I hope I'm communicating some sense of opportunity. But the opportunity doesn't really stop there, because the opportunity that we have today is the largest generation of young people relative to other ages that we have ever had on planet Earth. We are at peak youth. You hear a lot about peak oil, you hear a lot about peak water, but we are at peak youth, 1.8 billion young people aged 10 to 24. The shades in red show where we have the highest proportion, and over a third in some of these countries of the population are 10 to 24, shown in the pink colours, and the deep blue colours are where you have this high proportion of young people in the population. And yet in places like my own country of Australia, we have a scarcity of youth. The opportunity also lies in the global strategy for women's, children's and adolescents' health. This was announced at last year's UN General Assembly. This is the first time that adolescents have been on a global international development agenda of this scale. And again, the comment from the UN Secretary General in his comment is, young people are the world's greatest untapped resource. The potential here is one of a demographic dividend which could be transformative. The risk that we face is that of a lost generation if we don't actually get our investments right. The challenge that we have as a field was captured by the editor of The Lancet, Richard Horton, in a tweet from 2012. And those of you who know Richard will be delighted with this one. Adolescents, the most pervasively neglected group in global health. It's very Richard. And he's actually capturing something which is really important. It's not to say that there aren't great needs in terms of the systems, processes, resources, technical capacity in other areas such as the health of younger children and women's health, but this area has been particularly neglected. And so that brings me to the question of what we should be doing about it. But before I get there, I just want to pause for a moment around some terminology, because the terminology in this area is a little bit confusing. So there are these terms that you're likely to come across in referring to adolescence. So adolescence is that time between 10 to 19 years in terms of UN definitions. Youth refers technically to 15 to 24. Young people is a term that technically refers to 10 to 24. And then you come across phrases like this to describe the developmental years. And this is in no way comprehensive, and it's all quite confusing, not only for those outside the field, but sometimes for those of us inside the field. But this is the age group that the Lancet Commission is primarily focused on. 10 through to 24, we're trying to capture in this the essence of pubertal development, even though it does begin a little bit before the age of 10, which marks the onset of adolescence, and those transitions through to parenthood and marriage that have traditionally marked the end of adolescence. So, recommendations. We have 6 recommendations in this commission. You'll find them toward the end of the report listed in greater detail. And they really begin with this one here, is we need to begin to think differently about adolescent health. And let me illustrate that and what we mean by that. This is where the focus of adolescent health has been, up here, where the Millennium Development Goals were focused. It's been on HIV and sexual and reproductive health in the international development space. But sexual and reproductive health and HIV relate to everything else that's happening in health and the lives of adolescents beyond health. They relate fundamentally to what's happening in terms of nutrition and undernutrition, fundamentally relate to other infectious diseases, fundamentally relate to mental health, substance abuse, even to chronic physical illness. So where does the field need to move to? It needs to move to a broader conception of adolescent health that encompasses all of these health problems that can affect adolescents. We need to go broader and deeper still. The conceptual framework for the Commission is one that extends the conceptual framework from the 2012 series, and it very much places adolescence within a life course, recognizing that what comes before is really important, and that what happens during adolescence is very significant to what happens later in the life course. Our focus within health service systems tends to be on health problems and the response of the health service system. But as Soji very rightly pointed out, the determinants of adolescent health and well-being lie largely in sectors well beyond that of the health service system. So we need to be looking at health risks and the social determinants of health, and our responses need to encompass those community and structural and policy actions that address those determinants and risks. There's a fundamental idea here that's captured in this diagram about the need to match action to need, to health need. And an important message of the Commission is that if we get these investments right, we'll see a triple dividend from the investments. We'll see adolescents achieving their potential during the adolescent years in learning and growth. We'll see a dividend in terms of health and trajectories of health across the life course, and because this is the next generation to parent, the health and resources that this generation take into that task of parenting will be the best investment we can actually make in a healthy start to life for the next generation. So that notion of the triple dividend is an important one, we believe, in thinking about what we're doing about this field. Okay. The next slide is, for those of you who are fans of Sesame Street, is brought to you by the number 3. And that really is courtesy of Mariam Clayson, who's sitting here in the front row. And I'll explain sort of how that came to be, because when we were starting on this process of trying to design what this commission was looking like, we talked to a number of people in the policy space, and we were very keen that this wasn't an ivory tower academic exercise. So Susan Sawyer and I sort of received some words of wisdom from Mariam, which is to say what you need to do in this commission is tell us at the Bill and Melinda Gates Foundation what are the 3 things we invest in for adolescent health. Now, academics, you know, we're not very good at sort of that kind of simplicity. So we were taken aback, and this was one of these sort of elevator conversations. And I think we sort of sat down with a glass of wine to talk about how we might actually do that. But it wasn't long after that we had a similar conversation with Mickey Chopra, who's now at the World Bank. And Mickey, who at that time was head of health at UNICEF, said something similar. He said, look, it's really complicated for us in terms of planning and policies to work with a number like 192, which was the number of countries in the UN system at that time. And he said to us, look, if you could actually make some recommendations about the three groupings of countries, that'd be very helpful to us. So, in terms of this number 3, it appears many places through the Commission report, and really is that idea of matching action to need. Now, let me explain to you how we went about that in terms of defining need. And we worked with the Institute of Health Metrics and Evaluation at the University of Washington in Seattle, sort of in this work. And we worked with GBD 2013 data. And the metric that we used was the DALY, which takes into account years of life lost due to premature death and years of life lived with disability. We don't actually think that mortality is a particularly good reflection of the health problems that affect adolescents during these years, when many of the conditions that affect adolescents do cause significant disability, but they're not fatal. So what we did was to take the over 300 categories of GBD and reduce them to 3 groups of conditions. We defined diseases of poverty, which consisted of infectious and vaccine-preventable diseases, undernutrition, HIV because of its geographic distribution we took separately, and then the sexual and reproductive health problems that go with poverty and that affect largely young women. We defined a second group, which were a group of injuries. Unintentional injuries, violence, homicide dominated this group of conditions. And then we defined a third group of non-communicable diseases affecting adolescents: mental disorders, substance use disorders, and chronic physical illness. This reflects something of the direction of the epidemiological transition which happens with economic development, changing patterns of fertility and mortality that countries move through. And on this basis, we defined 3 groups of countries. We defined a group of countries where adolescents are affected by that triple burden, the multi-burden countries. They're affected by all of these conditions. And that group was defined by a daily count of over 2,500 per 100,000 per annum for these diseases of poverty. We defined a similar threshold in terms of injury excess countries, where it was these problems of unintentional injury, violence, homicide that dominated the picture. And you may already be thinking, whereabouts are these countries? I'll show you in a tick. And then the remaining countries where the predominant problems of adolescents are NCDs. So where are these countries and what do they look like? Well, this is the map. Apologies, those colours aren't as good as they should be. But the purple colour reflects those countries that are the multi-burden countries. So in sub-Saharan Africa, South Asia to a very large extent. The injury excess countries are shown in the orangey colour, and so these are countries of Latin America, Eastern Europe, Central Asia. And then the green colour reflects those countries which are NCD predominant. 51% of the world's population of adolescents are growing up in multi-burden countries. 51%, and they account for almost 2/3 of the disease burden affecting adolescents in the world today. Let me show you what's happening over time with that disease burden. And let me start with NCD predominant countries and looking at trends in health in these countries from between 1990 and 2013. So 1990 is shown over here on the left, and 2013 on the right. This is females and males. What you can see here is that in NCD-predominant countries, there's been an improvement over this time, but most of that improvement has been around reducing unintentional injury, particularly in males. Looking at injury excess countries, you can see here the excess burden of disease in these countries is largely affecting males, and it is the problems of unintentional injury and, in many places, homicide and violence as well. And then if we look at NCD-predominant countries, the multi-burden countries, we see that here there has been some improvement. The injury excess countries look a little bit stuck in terms of trajectories of burden of disease. For these countries, there has been improvement. The improvements have actually been more in young women than they have been in young men, and they have been around the problems of infectious disease and reproductive health, so there have been gains. The burden of disease is now somewhat similar to males and females in these countries, but the burden of diseases of poverty is still greater in young women than young men. What you see in these countries is the sort of this ongoing burden of unintentional injury and, to a lesser extent, homicide. And what's clear in all of these countries are these NCDs. They're not shifting in any country, whether we're talking about the United States and other sort of higher income countries, or whether we're talking about our multi-burden countries. Now, in the Commission report, we're going well beyond disease burden in terms of profiling health. And let me give you a couple of examples. First is what's happening around the health risk of obesity in this age group. This shows the current prevalence. This is actually, this bit shows the current prevalence in 2013, with the red colours showing prevalence of over 40% in countries of overweight and obesity. The blue colours are under 10%. There's not much blue on that map. Looking across our country categories, you can see that this trend toward high rates of obesity is already affecting our injury excess countries and beginning to affect adolescents in multi-burden countries. If we look at change, the pattern is stunning. Those deep red colours reflect an annual change since 1990 and 2013 of over 5% per annum. That is an astonishing rate of change that we're actually seeing in many countries. The grey countries are the ones where there hasn't been significant change in overweight and obesity since 1990, and there's very little grey on this map. And what you can see over here on the right is that that rate of change, particularly in young women, in multi-burden countries, is also accelerating at a similar rate to what we're seeing in injury excess and non-NCD predominant countries. And that becomes an issue not just of NCD risk in the future, it becomes a risk in terms of maternal health and the health of offspring as well. Looking at a very different picture, and one that's somewhat moving in the right direction, is adolescent birth rates. Here are the rates, current rates of adolescent births, with the deep red representing rates of over 100 per 1,000 girls per annum, whereas the deep blue represent rates of under 25. So there's still a huge variation across the planet in terms of adolescent birth rates. But if we look at rates of change, they're actually moving. The blue is good, the red is actually increasing rates. And for most of the world, we're actually seeing a favourable change in terms of adolescent birth rates, and that's a good news story. If we look across our categories in terms of current prevalence rates, the highest rates currently are in our multi-burden countries. But if you actually look at the rates of change, those are also the countries where we've made the greatest progress. And where we're making less progress are actually, interestingly, this group of countries that are the injury excess countries, Central Asia, Latin America. And if those trends were to continue, the highest adolescent birth rates in coming decades may well be in those countries. Okay, I want to move us on from patterns of need to what we should be doing about adolescent health. And the first thing I want to talk about is universal health coverage. Soji has already mentioned this. And if there's an age group in terms of achieving universal health coverage that is more important than any other, we believe it's the adolescent age group, who have their needs least well met of any age group currently across the population span. We explore in the Commission the reasons for this. And to illustrate that, I want to put up the UHC cube that many of you will be familiar with. So we explore some of the reasons within the system, why adolescents are poorly served. One of the reasons is that adolescent healthcare practitioners, or healthcare practitioners, find adolescents more difficult to deal with than any other age group. They feel less well trained to deal with adolescents, and this is a consistent story. We know that in many parts of the world it is the judgmental, the stigmatizing attitudes, the inability to maintain confidentiality that is a real barrier to adolescents seeking care around, particularly around health problems that are sensitive for them, around things like mental health and sexual and reproductive health. It is the reason why unmet need for contraception in sexually active unmarried girls is twice as high as it is in married girls. We explore some of the reasons beyond what is currently provided as well, why adolescents don't have their needs well met. We look at the financing envelope. Who is covered? Adolescents rarely are formally part of tax-funded or insurance-funded health care. They're dependent on their families. If their families don't have cover, adolescents don't have cover. If adolescents are living outside of their families, they don't have cover. The kinds of things that are covered by services aren't necessarily the major problems affecting adolescents. We've tended to do better around things such as sexual and reproductive health and HIV, but not other infectious diseases, not mental disorders, not chronic physical illness in terms of what is covered. Adolescents are the poorest members of most communities. They have the fewest financial resources, so they're the most sensitive to out-of-pocket costs. And if you actually have a catastrophic event affecting an adolescent or perhaps an adolescent's family, particularly for girls, this can be a devastating event in terms of future life chances. And we explore beyond the envelope of what we're thinking about in terms of current health service systems for adolescents. Currently structured adolescent health services don't necessarily work well for adolescents, and they don't necessarily take into account the developmental point that adolescents are at, how they're living their lives. And so we believe that there is a need to consider other strategies. We need to consider much more school-based healthcare delivery. We need to consider community-based strategies, mobile strategies. We need to consider the electronic and digital delivery of health services, either to improve access to traditional services or to deliver healthcare interventions. Now, the intersectoral bit is really important in adolescent health, and Soji's already flagged this. Some of the best interventions we can make in adolescent health are actually going to be in sectors beyond health, and we believe that one of the best investments of all is keeping kids in school and keeping adolescents in school. So Russell Viner and the team from University College London with Chris Barnell sort of undertook a series of analyses of the association between sort of education and a range of health outcomes, extending to mortality and maternal mortality. This one here is an illustration of the relationship at country level, so it's an ecologic analysis, but demonstrates the association between years in primary school and reductions in teenage birth rates. Extending secondary education for girls into lower secondary results is associated with a reduction of 48 fewer births per annum per 1,000 girls. That's a huge reduction. Extending to the end of secondary education is 68 fewer births annually per 1,000 girls, aged 15 to 19. These are huge reductions. The associations we find, that Russell and his team found, when looking at individual studies, cohort studies, were very much the same. The message is the interface between education and health is a really important one for this age group, and extending secondary education is a really good investment. Terry McGovern and her team at Columbia University did a second piece of work looking at the legislative frameworks around the health and well-being designed to empower young people around their health and well-being, or in many circumstances do the opposite. So Terry looked at 6 case studies, India, Lebanon, Nigeria, Peru, Sweden, and the United States, to ascertain how consistent the legal frameworks were across these different settings. What do you think? Do you think they're likely to be consistent across countries? Absolutely not. If you take something like the age of criminal responsibility, it varies from 6 to 18 years across countries and across offence. Take the minimum age for marriage, it varies from 9 through to 21 years across country. And you might say, well, it actually becomes more consistent, surely, as countries reach a higher level of economic development, but the comparison of Sweden and the United States really illustrated the huge differences between two higher income countries. And even within the United States, there are massive differences within states. And you'll see here these countries of India, Lebanon, and Nigeria, where the shading is in yellow around legislation. And these are settings where customary or religious law supersedes national legislation that might be good national legislation, but effectively customary law is the dominant law form, so that even if you have good legislation around a minimum age of marriage, what is customary actually sort of takes precedence. Terry is here, I think, today. I think, Terry, are you here? Terry, you're here. She'd be very happy to talk further. It was a fabulous analysis that she's done. The theme of engaging and empowering young people is a theme that we took very seriously on the Commission. We had two young commissioners, Kikalama Taiwo, who's here today, and Dakshita Wickramaratne. I still struggle with Dakshita's name. But they were fabulous contributors to the piece of work here that was, they worked with Suzanne Petroni from ICRW here in Washington, D.C., around this piece of work, examining the current evidence base for youth engagement and the models that actually work. Probably Kikalama is, I think, going to talk more about this, so I'm not going to say too much, except to say that if anything is overdetermined about adolescent health, it's the need for youth engagement and empowerment. Young people have the capacity to transform our thinking in creative ways that we're not utilizing, so we are not walking the talk. We, in our conceptual framework, sort of look at some of the underpinnings of youth engagement and empowerment and the need to sort of give young people the resources to do so. So Kikalama is going to be talking in a tick. Kikalama didn't just wake up one day and decide, I have everything I need to be a youth health advocate. It's actually the result of years of experience and training and mentorship. And we're not doing this in any systematic way. So currently, we believe there's a need for training of young people around the skills necessary for being effective advocates. We need to systematically put in place the partnerships and the mentorship for young people to ensure they do this task well. We need to ensure the systems and processes are in place so that it's not just token engagement, but real and meaningful engagement with processes and decision-makings that shape their lives. And young people need to be resourced to do this. So Kikalama today has got a fabulous employer, who has allowed her to actually come here today, but she's not being paid for actually doing this task that she's doing today, unlike the rest of us. We believe if we get this right, the dividends will be huge in terms of improved healthcare systems, not just for young people, but beyond young people, as well as it's good for young people to be engaged in these kinds of processes. Ultimately, it's better health capital and better human capital that we are creating in this process. So the last recommendation is really about knowledge gaps. And in some ways, this could be the most challenging and the most important of the recommendations. In the Commission report, we very much look at knowledge gaps within the framework of accountability. And I'm going to do so here in terms of talking about them. So, first step in the accountability is taking the account. And it's fair to say that we have some real challenges in this field about how we take the account. We have a tremendous problem with our primary data. Our current systems are haphazard, poorly coordinated, little harmonization. So we have huge gaps around our knowledge of health problems at a global level, at a national level, at subnational levels. Our focus has tended to be on sexual and reproductive health and HIV. Other areas, including other infectious diseases, our knowledge is thin. Problems such as substance abuse and mental disorder, almost non-existent in many places. We have a real challenge here. We have groups such as younger adolescents, adolescents who are out of school, who we're not capturing any data at all on. So there is a big challenge here, and we're going to need to harmonize our data systems better. We're going to need new data resources. But we do believe that there is an opportunity to use some of our existing data better than we are currently. So in the Commission report, we give the example of Nigeria. We had 2 Nigerian commissioners who we consulted with about this. Do not try and read this. Do not try and read this. It's really to illustrate that it's there in the report. Look at the report. To say that we can actually now put together a fairly good estimate of the burden of disease and the things that are affecting adolescents in any country. We can talk about the health risks affecting adolescents in any country. We can talk quite a lot about the social determinants and the service platforms that exist within any given country. And on that basis, we can come to some fairly broad but valid recommendations about what the priority health problems are for adolescents in any country. But we're not currently doing this. We can even sort of look at subnational profiles. So we looked at the subnational profile of China. China, on the whole, Chinese adolescents are actually doing pretty well in terms of their adolescent health. But we had a Chinese commissioner who said, oh, no, it's very different in different parts of China, and she was right. In the eastern provinces, the problems of adolescents are largely NCD predominant. The western provinces, the problems are actually a mixture, and they're better classified as injury excess, not NCD predominant. And that's true of every country. Our accountability process went on, from talking about taking the account to sharing the account. And again, this is sharing the account and sharing data, not just with government departments, but sharing it with civil society, sharing it with young people and young people's advocates and young people's organizations. We're not currently doing this. It's about the need to create forums where civil society and young people can discuss with government the investments that governments are making in adolescent health. We currently don't have those forums. And it's then about responding to the account. Now, part of the story, as Sochi, I think, eloquently said, part of the story is matching action to need. And needs vary hugely, and responses vary hugely within countries, between districts, between states, and between countries as well. And it's also about using the best evidence-based practice. So you will find the most comprehensive meta-review we think has ever been done of what works in adolescent health within the Commission report. That was was led by Nikki Reevely, who's based with us at the University of Melbourne. It was a huge undertaking. And I've put together what is a qualitative evidence gap analysis of what we know and what we don't know. So this is my interpretation of this meta-review that really covered all of those 9 areas that I described earlier and related health risks, and just picked out a few in terms of what we know. And what we know well, or reasonably well, is shown in green, the deep green. The paler green here represents those interventions and actions from platforms. So these are 6 different platforms across the top and the health problems along the side here. The paler greens represents those areas where we have some promising actions, where the reviews are either mixed in terms of the evidence base or the evidence only comes from high-income countries and mostly from the United States. The other greys represent those areas where we just don't have the evidence. The paler grey where we have perhaps some studies, the deeper greys where we have no studies. And what I want you to see is that there's a lot of grey on this palette. Now, you might say, well, it's looking pretty good for sexual and reproductive health and HIV, and you're right. That's where the best evidence lies. And I think there's little doubt that conditional cash transfers work to produce good sexual and reproductive health outcomes. Evidence around comprehensive sexuality education is pretty good. And increasingly, the evidence about youth-responsive, youth-friendly sexual and reproductive health care is actually pretty good. But even if you look within sexual and reproductive health, there are huge gaps in our evidence base. We were surprised, for example, there are almost no studies looking at families in relation to sexual and reproductive health. Why not? Families are the most important entity. 1 minute. I think I'll be pretty good. Okay. Are really important in the lives of young people, but we're not looking at them in terms of the intervention base. We don't have cost-effective analysis in many low and middle-income countries around something we know is important and works, comprehensive sexuality education. Looking at these other areas of importance, we've got a largely grey palette around sexual violence, where the evidence that we do have around community interventions comes from largely high-income countries, around obesity. Again, the evidence is thin and looks best around policy policy interventions, taxation in particular. We have really promising areas and platforms such as E and M health platforms that we're just not looking at. And where we are looking at them, we're only looking at them in high-income countries. So there's a huge agenda of work here. Lastly, we looked at the drivers of the accountability process. We placed young people centrally in this, and Kikiloma will say something more about that. And we also talked about the importance of independent oversight. Adolescent health. It's been an area which has been everywhere and nowhere. At a global level, it's everywhere, but there's no clear point of accountability. And again, at national level, it's the same kind of thing. So we flagged some suggestions there about national youth commissions as a possible mechanism. I'm going to finish now. I just want to acknowledge my colleagues, the commissioners. I want to acknowledge the lead institutions, Columbia University, London School of Hygiene and Tropical Medicine, University College London, and the University of Melbourne, who formed the partnership that underpinned this. I want to acknowledge our funders, the MacArthur Foundation, and in particular the Bill and Melinda Gates Foundation, without whom this work wouldn't have been possible. And I'll leave you with the words from the front cover. This generation of adolescents and young adults can transform all our futures. There is no greater priority in global health than ensuring they have the resources to do so. And with that, I'm going to pass you over to Kikiloma Taiwo, who was one of our 2 youth commissioners, who's going to be talking more, I believe, about the youth engagement and empowerment strategy. Kikiloma was, at the time, based in Nigeria, but she now lives in New Jersey, and so it's been a shorter trip for her today.
Wow. Good morning, everyone.
Good morning.
It's such an honor and privilege to be here this morning. Thank you very much, Judge. And let me also say thank you to all the other commissioners who have been a huge support and have been mentors to myself and Dakshitha, who's not here. I see Nicole Cheatham right at the back. Good to see you, Nicole. Nicole has been a remarkable mentor in my life, which I'm going to be talking a little bit about how I got started in youth engagement and youth advocacy, and just, basically describe what my trajectory has been in and on the commission. So I got involved in volunteering when I was 21. I was a young woman growing up in Nigeria with so much energy and passion. And all I really wanted to do was to help young people unleash their potential. So I got into this volunteering program that trained young people as advocates. Specifically, we worked to engage policymakers to support young people's sexual health and to reduce stigma and HIV and AIDS, which was and still is quite significant in the country, in Nigeria. One of the first things we did, or I had to do with my team of fellow youth advocates, was to recognize that whether or not we were HIV positive, we were all affected by HIV/AIDS. We realized quickly that by just being a young person in a country where young people accounted for over 60% of the total population of people living with HIV at the time, it was our responsibility to take action on behalf of our peers. We came up with several innovative youth ideas about how we wanted to engage adolescents and young people around the country to reduce HIV stigma. This was something we all had never done before, but we were also enthusiastic and passionate about making positive social change happen. We worked together with the support and guidance of adult advocates to review the Nigeria HIV/AIDS anti-stigma bill, which was under development at the time. We discovered that the policy document was heavily focused on stigma and discrimination in the workplace. And even though we believed there shouldn't be stigma and discrimination in the workplace, we understood that Nigeria's youth population was faced with a high unemployment rate, and if the bill was passed as it was, it wouldn't really do much to protect the rights of this most vulnerable population. So we decided to write up our recommendations and fight for them to be heard. And they were. we were given the opportunity to present these recommendations at a public hearing at the Nigerian National Assembly. At the same time, we facilitated other national-level campaigns to educate and enlighten young people about the need to contribute to policies and programs that affect their health and development, specifically training young people living with HIV. The feedback we got from the universities and the Association of Young People Living with HIV was tremendously positive. We also hosted a radio show specifically designed to serve as a platform for young people so they could share what they wanted to see in the policy document and could dialogue with policymakers via radio. The feedback we also got on this platform was phenomenal as well. For the first time in the HIV movement, young people across the country felt connected to their policymakers, and there was real engagement that yielded a positive outcome, which I am proud to say was the passage of the bill with specific language that young people pushed for. The success we encountered would not have been made possible without these three things. And I mean, these are things that George alluded to in the conceptual framework that we saw earlier. And they are training and mentorship, adult partnership, and systems and resources. I'm going to touch on these individually, as the Commission report also does. First, training and mentorship. The evidence is clear. Young people will deliver even better results when they are trained and mentored by supportive adults and by other youth. Training and mentorship enhances adolescents and young people's capacity to be creative, confident, and consistent. I couldn't have done all that I did without the support of my supervisor. At first, I was very timid and struggled with low self-esteem, as many young adolescents do. My supervisor at the time would always acknowledge my efforts and challenge me to even do better. He made me believe in myself so much that I started to do things I never thought or imagined I could do, considering the fact that I was still just an undergrad at the time. One of those things was applying to join the Lancet Commission. I recognize that my role here is one that is very significant, particularly as a young African woman, and I honestly would not have been able to pull off a compelling application without the training and mentorship I had received. More importantly, while I think my application must have been compelling, being in the Lancet was an entirely different space that I was often intimidated by, given the caliber of the other members. Nonetheless, many thanks to my mentor and ally, Susan Petroni, right here. Yes, who always made sure myself and Dakshita understood the why, what, and how, and the how of everything that was going on at times when we were overwhelmed. Like, these people will be blowing some heavy grammatical language, and we're like, okay, what is that about? And Susan will be like, calm down, they're referring to this and that. Which further reinforces the idea that adult partnership is very important. I honestly can't emphasize enough the need for continuous training and mentoring for young people in order to facilitate meaningful engagement. The second is adult partnership. This is linked to the first point, of course. Whilst there is a place for mentorship and support, the relevance of true youth-adult partnership cannot be diminished. However, in order for this partnership to be meaningful and balanced, adults themselves need to be trained on how to communicate with and listen. Like, really listen. Just listen to adolescents and youth. This partnership must not be tokenistic in any way. Adults must accept that young people are experts in their own right and with their own experiences. And they have to understand that, though they, adults, were once young, the times have changed. Yes. As George discussed this morning, adolescents and young people have to balance many social, environmental, and individual demands and factors. Adult partners need to understand that adolescence is a critical period of transition that comes with many internal and external changes that even the adolescent is trying to figure out. The key for adult partnership, again, is to engage young people as equal stakeholders, particularly on issues that affect young people themselves. And finally, systems and resources. These two underpin meaningful engagement and participation. Without adequate resources and systems that recognize young people as equal stakeholders on matters that affect them, adolescents and young people will be isolated and remain marginalized. Resources are needed for training and supporting adolescents and youth to engage, and resources are equally needed for adults to learn, partner, and mentor young people. And as we found in our research and the Commission, resources are also needed to implement youth engagement at scale and for measuring and evaluating the impact of youth engagement. Even as the global community increasingly comes to agreement that meaningful youth engagement is a right, we must recognize that meaningful youth engagement cannot happen without serious investment. This should go without saying. Where young people are trained and mentored by adult partners who themselves are trained and mentored and who truly understand the importance of youth engagement, and where there are adequate resources and platforms to support youth in engaging meaningfully in programs and policies that affect them, and where there is significant investment in systems and structures and capacities, adolescents and young people will contribute meaningfully and powerfully towards improving their health and well-being and those of their peers worldwide. Thank you. I think I'm going to stop there. And let me also quickly say this. Just give me 1 minute. Give me 1 minute. I think that one of the ways the Commission itself has embodied these principles, obviously, is by having myself and Dakshita as active members in the Commission, as co-leads of the youth engagement piece of the Commission's work. But we are also supported to implement these ideas and capture the true needs and voices of young people around the world. Hence the Global Youth Survey that George mentioned earlier. The electronic survey was designed by those of us on the Commission to ensure that the Commission truly reflected from a global perspective the voices of young people, and to also give young people, youth health advocates from around the world, the opportunity to inform areas we as a Commission should focus our attention on and how we should best frame our key messages so as to support them in advocating for adolescent health and well-being at the local, national, and global levels. More than 500 adolescents and youth adults from 83 countries working across a range of health issues participated, and their perspectives mattered. The contributions they provided us were incredibly helpful and helped us to really place the engagement of young people to the fore and center in our work. For us at the Lancet, this is what meaningful engagement looks like. Every adolescent and every young person has great worth and potential to be the next big thing the world has ever seen, and possibly to provide solutions to the world's most difficult challenges. It's time we stopped paying lip service to youth engagement and paid forward through prioritizing investment and actions to engage adolescents and young people meaningfully. Thank you for listening. Okay. On that note, I would like to invite Dr. Susan Sawyer to come and facilitate the next session. Please put your hands together for her as she comes up. And I would also like to invite Dr. George Patton and Dr. Sabine Kleiner to join me for the next session.
I think you can appreciate that many of us feel very excited about the safe hands we're in when we can see such incredible capacities in our young people that truly are our future, the name of our report. So we now have, we've got a little bit of extra time that I've managed to skerrick from our organisers. Thank you, Jessie. So we've heard a lot this morning, but as Sabina Klein had introduced this whole morning with, the opportunities now are moving forward, and moving forward is something that we do firstly in partnership with young people, but particularly in partnership with you, civil society embodied in the audience, with all of the multiplicity of colours and stripes and shapes that you each represent. So we have 2 roving mics. We have about 20 minutes now for questions. So could I have our microphones standing up, please? And the first, we'll take a couple of questions and then I'll hand back to the panel. So we might have 3 questions to start with. The woman in pink was first up. There's a woman down the back of the room with her hand up as well as the next question.
Hi, Jill Gay, What Works Association. My question is brilliant idea on preconception care, but in lower and middle income countries where it's very needed, there doesn't exist such services by and large, and it's particularly critical in terms of HIV. How can we get that institutionalized? And my other question is, we know that sex ed works, but it hasn't been scaled up except with Nigeria and Colombia in any of the lower middle income countries. So how do we get what we know what works scaled up?
Question at the back of the room.
Hi, Lyric Thompson with the International Center for Research on Women, and I am an advocate, so I want to make sure I'm getting my talking points straight here. A couple of the findings that you mentioned, Dr. Patton, were kind of contrary to some of the talking points that we usually use in our community. One, that education is the single best investment for SRH outcomes. Are there any caveats there in terms of, would you couple that with CSE? Would you give us some kind of additional detail on what that should look like, how to structure that effectively? And then the other one is also just if there's any concern that the top line finding that SRH is where we're seeing the best outcomes might, be taken to rejigger investments in other areas. Are we on a trajectory that we need to sustain current investment, or is there something that we can say there? Thanks.
And I'll take one more question at the back of the room, and then we'll complex questions, each of them. So we'll stop at that point.
Hi, Eliza Waxman, USAID Africa Ebola Unit. Dr. Patton, before you were talking about engaging a younger cohort of adolescent girls in research and the need to identify strategies that are best tailored to that population. Some of the challenges that I've encountered in my own previous research is the ethics around engaging a younger cohort of adolescents. And I'm curious as to what kind of policy work is being done to address the need to tailor interventions to that population and to engage them in the appropriate research to get to that point. Thank you.
Okay, let's start with those 3 then. Sounds like, George, that's over to you.
Right. Look, fabulous questions, and there's a lot of complexity in each of them. So let's start with preconception care, and it's an idea that time has certainly come in a sense. And I think we sort of understand now that there are processes that carry risks for mums during pregnancy and for sort of the offspring of the next generation that really begin during the adolescent years and that carry forward sort of into the sort of antenatal and postnatal time. And I think we're increasingly clear that some of the best interventions we have are going to take place prior to conception. And that's not just around infectious disease, it's around nutrition. It's around things like mental health that we haven't actually looked at, but increasingly the evidence is that maternal mental health problems often have a long history prior to conception. So I think that's the agenda that we now need to be looking at, and it's actually one of the drivers, I think, of interest in sort of adolescent health. I'm not sure that preconception care is necessarily going to be the answer, and I think we need to look more broadly sort of at adolescent health and adolescent growth and the resources that we're providing for adolescents during these years. Nutrition is a really good example where nearly all the studies that we actually have been around pregnant adolescents I actually think we need to be looking here at sort of nutrition of adolescents more broadly. We know there are significant problems with undernutrition in many parts of the world. There's a macronutrient and micronutrient deficiencies that affect adolescents. Iron deficiency anemia is not a bad indicator of the level of those micronutrient deficiencies. You know, we need to be working sort of, I think, well prior, sort of during the adolescent years. So I think the move from where we sit is move beyond preconception and move to adolescent health more broadly. Your second question was really around scaling up. And scaling up, this is the big thing. It's really about taking what we know. Now, we need to know more than we currently know, but we do know about some things that work. I think there have been some technical barriers there. Sort of costing has been a real problem. You know, we look for cost-effectiveness analyses. The work just hasn't been done. Where work has been done, it's been based around single studies. They've not been on proper syntheses of the evidence in any particular field. Often, as I flagged, it's been in high-income settings. We don't actually know what the costings are for many actions in many settings. So if you don't know the costings, it's actually very difficult to scale up. I think, you know, it's tied into sort of having better data systems within countries, so we actually know where these things actually need to be scaled up. Don't necessarily need to do everything everywhere within a country, and, you know, needs vary hugely. So better data systems are going to be really important. But I also think it's sort of just, you know, deciding, okay, what are the three things? You know, coming back to Marion, what are the three things we actually need to focus on in a particular place? That might be at a country level, or it might be a state within country. So I think there's no simple answer to your question, but I think those are some of the processes we need to be looking at. And so there's a whole interest now in implementation science and how we do that in adolescence. The question about secondary education, there's a huge, it's a really timely question, and this interface between sort of health and education, given that we now have the UN Commission on investing and financing of education, I think it's a time that we need to be looking at sort of how it is that education is so protective in terms of health. I think that sort of part of that is, and all we have looked at in this commission is a simple indicator of years in education. We haven't looked at quality of education and what's actually provided. Though we did actually look at some of the evidence of what works when you're actually looking at schools as a platform, and schools are potentially an incredible platform. But I think schools have intrinsic value for kids. And the value is likely to come from being, in many places, and this is really important, is a protective environment. Now, schools aren't always a safe environment. Let's be clear, particularly for girls. And we need to make them safe environments. But by and large, they are a safe environment for kids to be in, and a protective environment. Kids learn skills that are really important in terms of their health during those years in school. Probably a range of other processes that are also important, and those processes are likely to be more effective the higher quality of education that we're actually providing. And that's another debate and another discussion that we actually need to have, is what is actually quality education? And it's about more than simply academic grades. It's about learning the social, the emotional, the skills, the soft skills, for whatever industry one might be moving into, but also those skills are really important in terms of life and the tasks that are to come. So I think a broader view of education is important, and yes, we do explore schools as a platform for healthcare delivery, and we actually think that we've not in any way utilised that potential yet.
And the last question in terms of research on young adolescents in particular and the challenges of
thank
that.
you. Thank you, Susan. God,
Well, John Santelli's in the audience, and I know as one of the commissioners how importantly he values this, and I know that he'd be very upset if we let that one through to the keeper. So,
yeah, John, would you like to comment?
Perfect with the microphone.
Sure, I used to chair an IRB and did a few things like that. But the Society for Adolescent Medicine has put together, I think, some very helpful guidelines on this, and on how to involve young people in research, and how to involve them ethically, and there's a lot of practical difficulties. But actually, George and I are also working on a Lancet research brief on how to do that exactly. I mean, I think the problem...
You mean a UNICEF research brief, I think.
Did I say that right?
Yeah, it's not a Lancet research brief.
Oh, yeah,
it's
oh my
UNICEF
gosh.
research brief.
Thank you. Everyone needs a good editor. Thank you both.
I've got your back, John.
I know you do. I think the fundamental problem is we've misconstrued the the brain science, the ability of young people to provide informed consent, to participate, as Kikoloma said. And so we have this situation where we've excluded younger adolescents, particularly from research to which they would benefit. We need to change the global standard about that. We need to protect young people, but we need to involve them in research.
So one of the messages of the Lancet Commission was very much how do we both protect young people and put in place the systems and structures that are protective of young people whilst at the same time empowering young people and supporting their engagement and participation. And I think the question of research, particularly low-risk research, such as survey research about health risk behaviours, for example, is one that we would see very much as one that we are needing to be supporting the participation and engagement of young people rather than some notion of heavily protecting young people, which I think, I can't now remember this beautiful language we use, we're protecting them to the point of invisibility, I think you'd used at the timing of the Lancet launch in London.
I could just add, sort of, there are some technical and cultural barriers as well that are really important. So there are many things that, one can't easily, currently, sort of given cultural norms, actually survey sort of adolescents of any age about in many countries. So areas such as sexual and reproductive health, substance use, alcohol use are the kinds of things that surveys that we currently have actually are not included in many, many countries. And I also think there's a technical piece of work that needs to be done. So technical work about what are actually the indicators that we should be collecting data on in adolescence is a piece of work that hasn't yet been done for many areas. We're a little bit clearer about them in terms of sexual and reproductive health, but that's a technical investment which is actually a barrier to collecting the right kind of data that we need to be collecting on not just younger adolescents but older adolescents as well.
A really important take-home message in the report. Let's have one final round of questions. Make them brief and make our answers perhaps brief. There was one here, one in the woman in the pink, and then the woman in the blue just behind the microphone at the front.
Thank you to the panel and to Dr. Patton in particular for very elegant presentation with some very interesting graphics and frameworks. So what my question, and I am going to just elaborate on it for a second to explain the context a little, is so what is the biggest idea here and what's new and different? And having followed the adolescent literature for some time, almost 2 decades ago we had the second decade, which talked about sexual and reproductive health and injuries and mental health. Then we had the National Academy of Sciences Growing Up Global, which really underscored the intersections between between education and health and the importance of connecting those domains. So I'm sort of trying to be a little provocative and say, what is new and different, and what's, as there's a political blog that says, what's the big idea here, the biggest idea
Let's
here?
take that as a question. The woman in the pink just behind here is the next question. And if you could introduce yourself before your question, please.
Hi, I'm Marjorie Macieda, and I have a question for Kiko Limo?
Kiki, yep.
Kiki Limo, okay. How are we going to change adult attitudes? Because I think it's really difficult to engage youth. I mean, we can have the systems, we can have mentors, but there's still an attitude change of trusting young people and making space for them and, just really putting them at the forefront. How to do that? I know that's tricky.
And then the question here with the woman in blue.
I think, is it on? Thanks. Good morning. My name is Sonia Cafe. I work at the Pan American Health Organization as an Adolescent Health Advisor. Thanks to the panel for wonderful presentations. My question is the following. How do we ensure, you just mentioned the whole issue of indicators, of measuring. How do we ensure that we instill and that we incorporate in our measuring the whole issue of equity? Because not all adolescents are the same, not all have the same risks, and if we are speaking about this urgency that we need to intervene, I have missed that even a little bit in the SDGs, so how do we ensure that? Your thoughts on that?
Really important question. Kiki, why don't we start with you in terms of how do we listen better to young people?
Thank you very much for the question. I think it's a very critical question that obviously needs to be addressed. I mean, one of the things I think, and like I mentioned in my remark, was to train adults wherever young people go to get services or to go to school, wherever young people are interfacing with adults. Those adults need to be trained on how to be able to better serve young people. Because, I mean, while we understand that, yes, it's important to train young people, it's important to listen to young people, but we also need to understand that these young people are going to be interfacing with adults as they go about their, daily lives. So I think that, training adults wherever they have to interface with young people, and I think that one of the critical place that we need to begin that is within the family system. Let's start with the parents. Within the family environment, how are parents communicating with their children? How are parents interacting with their children? Are parents even listening? And then we'll take it to the health center, to the education sector. But essentially what I'm trying to say is that, just as training young people is important, training adults is also important. So the opportunities that we create to train young people, we should bear in mind that as we do that, there are adults that would need to be trained as well, and also making sure that the resources are available to do that. Does that make any sense? Do you understand what I'm trying to say?
Thanks, Kiki. And George, big challenge. What's the big idea? Haven't we heard it all before?
Look, provocative questions are always the best, so thank you. Look, we're clearly building on things that have gone before, and there have been many. Growing Up Global, certainly, sort of the World Development Report from 2007 was a really significant step. I actually think, some of the reports, the Lancet series, the Health for the World's Adolescents, some of the reports out of UNFPA, these have been really, UNICEF as well, have actually had sort of important reports that have been really increasing in number. It's really been an accelerating trajectory. I think there are some things, though, that are new. I actually think sort of the data down to country level. And Ali Muqdad's accompanying paper goes into a hell of a lot more detail of actually having profiles of health and health risk down to country level is actually new. I actually think that some of the meta reviews that we've done to do this so comprehensively across all health conditions, I think is really new. I think some of the work at that interface of education and health is actually new. We haven't actually seen it in this form before. So I think there are elements that are new. But the big idea, I guess, is really one about this interface between what's actually happening biologically, what's happening sort of in terms of the growth of the individual, and the interface of that growth with the social and cultural world in which an adolescent is growing up. And that is an idea that we begin to explore here. It's an idea which is a critically important one in terms of how we frame legislation, how we frame public policy. And I think that's actually a really big idea that we haven't seen explored in those previous reports. I'd probably say that in terms of increment, the narrative is the most comprehensive narrative, I believe, to date. I'm not saying that narrative is yet complete, but it's a different narrative to the one that we've actually seen. So in terms of the question about equity, gosh, that's so sort of important. And, so, we need to, when we have an indicator, we need to be sort of looking at stratifying that indicator by gender, number one perhaps, wealth quintiles, urban versus rural. There are huge differences geographically. And in some places you'll need to extend that according to sort of to the nature of the culture. In India by caste, for example. It would be an important stratification. So whatever we are doing, we need to be stratifying by these really important markers of inequity.
And George, in terms of our global data measurement systems and how well they measure the unequal lives of young people, would you care to comment on, for example, school-based surveys and population surveys?
Look, I don't think we're sort of nearly at having that level of granularity that we actually need to sort of look at. I'm not sure that our surveys of this age group are large enough or comprehensive enough to actually be able to stratify by much more than gender in many instances, certainly not by sort of geographic differences, perhaps by wealth quintiles. But if you're doing a survey, a school survey sort of in younger adolescents, which is the only real health data that we have of younger adolescents, in many places, it's the adolescents who are not in school who are the ones that one wants to know most about, and they're not in your sampling frame. So we have a long, long way to go.
In terms of equity, though, I'd also make the final point that in terms of the SDGs and the indicator framework around them, I think there is still recognition that many of us would have that where that has landed doesn't serve young people well. And in the Lancet Commission, there has been a proposed set of 12 interim indicators that are really trying to, in a, if you like, interim fashion, try and bring visibility to young people to be ensuring that within the global strategy they really have the visibility there that will be supporting future investments being made. Now, I'm aware we've got about 3 more minutes, so let's have 2 more questions. And this is the back of the room. I saw a slew of hands before, so that have all suddenly disappeared. Have we answered all of your questions? So here they are all over again. So the woman there and then the woman on the other side of the corridor, our last 2 questions.
Hello, my name is Nicole Cheatham with Advocates for Youth, and I have a question for Kike Lomo. I was just wondering, having served on the commission, and what your thoughts, what was an aha moment for you in terms of the findings of the commission? What struck you as particularly interesting?
And the last question, then the woman just beside.
I'm Nandini Uman, formerly at CGD, and as they say, you can leave CGD, but CGD doesn't leave you. So I have a question about sort of how donors, I understand that the new idea is basically new research, and there's more evidence, but not as much as we would like. So, but the main issue is, it's not so much it being a new idea, because adolescents are, I mean, it's a permanent thing, right? We just get new cohorts of it. How does this actually take action at the level of national and subnational governments? Because in the past, I think the sell was demographic dividends. This is an economic argument for countries, so governments are more likely to sort of absorb that information and take it forward. But it isn't clear to me, even though it's great research, and I want to compliment you on the effort, I'm just not sure how this actually gets translated to actual results with interventions on the ground that match it.
Kiki, very quickly, take-home messages of what you've learned.
I think that for me, one of the aha moments that I had was, with the recommendation that George alluded to earlier about matching action to the area of need. And it just, and it sounds pretty basic, but we're not doing that. And I think that sort of, provides some kind of focus, even as we go forward in advancing the movement, the adolescent development health movement, that as stakeholders, as governments, as civil society, as donors, we need to match action to where there is the most area of need.
Thanks, Kiki. And George, last word.
Look, that's a great question. It's got many different sort of elements to the answer, and one could sort of address it at a technical level. But I think the sort of flavour of what you were saying was really about politically, how do we sort of get traction? And that on the one hand, there is this idea of the demographic dividend that's been a sort of really appealing idea, but hasn't perhaps got traction. I think we probably do need to look at the other side of the ledger. And Kiki, I think, flagged this, that the world today for this generation is incredibly different. The level of social change, social upheaval, conflict in many parts of the world, migration, the problems of no jobs, so not enough jobs to go around. I think the changes that we're actually seeing in expectations, Soji flagged this, around sort of the spread of the new media, I think these are sort of huge challenges that carry significant risks. So I think in terms of politically, I'd be saying there's a positive side to this story, but I think we need to be mindful of the risks. And I think both sides of the argument are actually going to be important in terms of getting political traction. And here I just want to come back, to young people. Young people are incredibly creative agents of change. I don't think we've stressed enough. But, that having them in the process, challenging sort of accepted norms, challenging cronyism, challenging corruption, which is a significant problem in many places. They are essential partners for us in moving forward. Not just, I think, in adolescent health, but I think in global health and international development more broadly.
We could carry on this conversation all day, and in London we did have an all-day conversation about this, but we are going to have to draw it to a close. We will be breaking now for morning tea, regrouping at 11, so please join with me to be thanking all of our participants this morning.